Well, welcome back everybody to our first panel discussion of our second day. For those of you that weren't here yesterday, my name's Dr. Gemma Stacey and I'm the Director of the Academy at the Florence Nightingale Foundation. And this is my opportunity now to introduce to you Greta, who you have already met and are aware of as our CEO of the Florence Nightingale Foundation. But most importantly to her, she is also a nurse and a midwife. Most of Greta's clinical career has been in genetic counselling, but it was when she was really making waves in the world of clinical academic careers that our paths first crossed. And actually that was back in 2016, when I've looked back where we met in Brisbane, Australia at a conference. And one of the things that really stood out to me at that time was that there wasn't a pathway for clinical academic careers that was established at that point. And Greta was one of those people that was able to work creatively to identify collaborations, develop processes that enabled practice and higher education to work together to really establish this career pathway. So she really was a pioneer in this area. Now, Greta's commitment to identifying the talent of nurses and midwives within the workforce and using every option she has available to her to really enable their opportunities and give them platforms to develop is what drives her, and it motivates her to work so hard every single day for the Florence Nightingale Foundation. And actually, when I think back to my first few weeks at the foundation back in January, I said to her, Greta, I think you're like the fairy godmother of nursing. You're just going around granting all of these wishes and making people's dreams come true. And actually what I realise now that absolutely is the case, but she's driving our organisation to a place where this will be achieved at a systems level for thousands of nurses and midwives across the whole world. And what an honour it is for me to be part of that. So to the panel today, I know that with Greta at the helm, you will have a fantastic panel discussion. We're focusing on impact. We have the most talented and knowledgeable panelists to join us. So enjoy. I'm sure it will be inspiring, challenging and thought-provoking. Over to you, Greta.
Thank you, Gemma. Gosh, it's a bit of an emotional morning this morning. Like spending it so far, it's only 11:30 in UK time with a lump in my throat. Anyway, I shall clear that now to move on to this third panel session. And this session, as Gemma said, this is about impact. So what is the professional impact that nurses and midwives are making on the state of our nations? And how do we demonstrate that evidence? So the foundation, Gemma alluded to the things that we're doing to enhance our offer to nurses in the UK, midwives in the UK, but also globally. So we've recently launched membership of the F&F Academy as we want to support senior nurses to come together to try and identify better ways that we can evidence the work that we're doing, and in so doing have an impact on developing our policy. So this morning, yesterday, we've already heard examples of impact, but I guess I want this panel to go a little bit further with our thinking. So what else can we do to demonstrate our impact? What do we need to do to shake off the superhero, the angel title? And what can we do to change our narrative to showcase the fact that we are highly skilled professionals? So as Gemma introduced her previous panels, this panel is no different. I gave the panelists only the title. There was no other brief. So they've been asked to talk for about 10 minutes each on their own interpretation of this subject. And I hope you agree that we've convened an expert panel, and I can't wait to hear their presentations. So, ladies and gentlemen, may I introduce the panel? Susan Aitkenhead, she is the Deputy Chief Nursing Officer for England, so in the team of Ruth May, who you heard from yesterday. Colonel Sharon Findlay, she is the Defence Nursing Advisor for all 3 UK military services and a very valuable trustee of the Florence Nightingale Foundation. And Professor Bridie Kent, who's the Deputy Director of the Doctoral College at the Faculty of Health at the University of Plymouth, England. So wow, hold back, sit back in your seats and enjoy the next session. Susan, over to you.
So thank you, and hello everybody, good morning. Thank you so much for the invitation to talk to you today as well. Really delighted to be here. Great supporter of the Florence Nightingale Foundation. I was honoured to have the award early in my career, which really was so valuable and the fantastic work that they do. So as I say, delighted and really happy to talk about impact as well, which is very much central to the work that we're doing now, led by Ruth, which I'm sure she touched on yesterday. So as I say, really pleased to be talking about impact, and also I would like to talk about impact and align it to how we position our leadership going forward as well. And I'm sure all the presenters yesterday and today have alluded to this, and I make no apologies for alluding to it again. But the last few months have been unprecedented, tough in a huge variety of ways for everyone. And I don't make any apologies to repeating what other colleagues have no doubt said. I think nursing as a profession has been integral to the response. And as we move into this new normal, whatever that new normal may look like, we continue to strengthen and position our leadership in this space. One of the things that I think has been very interesting as we move into this new way of working and talking about impact and our leadership is that we are working already, I think, in a different way culturally. We are now looking at the evidence as business as usual. We're all very used to, I think, on the daily. So I think previously, hopefully, I was heard up to the point that I was saying that I think from an impact perspective that now moves into a new way of working, and I think that we're so used to now starting to look at the data and the evidence. And this was probably kicked off, I think, when in the first wave when we were looking at the evidence on a daily basis and all the graphs and data that was put forward to us. But this has now started to become more firmly embedded in everyday operational processes. And I think it's really important as a profession that we continue this examination. And by continuous examination, I think we can understand how our impact continues. So I want to take the opportunity this morning to talk a bit around that, which is slightly different to my other colleagues, which is hopefully helpful as well. Hopefully, if we can see the next slide, I had some pictures of some of the work that we've been doing nationally. And the work there is really building on the learning that we've actually so aware of. It's been happening around the country. A huge amount of learning gathered, and I think we have a professional connected with colleagues right across the country and the globe as well. I think the slide's stuck, but if we can move it on, there's some pictures there which I think will be accessible after the event anyway, which shows you the work that we've on trying to capture that learning at a national perspective in the national nursing team, and Ruth may have touched on this yesterday. We're really keen to make sure that information, experience and innovation is spread and scaled up, and it's one of the privileges that we have working nationally, that we actually have the opportunity to share learning across the country. I think we need to do this because we've got a duty of care for those that we care for. If there's something that's working particularly well in one part of the country, then we need to share that with others. Also for those we work alongside, and colleagues have already touched on this morning about the importance of looking after our staff and that health and well-being, particularly with the difficult challenges that we've been through and continue to go through now. And also for the future direction of the profession as well. I think that impact and the evidence that we've gathered over the last few months and going forward really gives us that opportunity to look at what do we want from nursing in the next 5 years, the next 10 years, the next 50 years. And if we have this evidence to really capture and demonstrate what we're doing on a daily basis, then that really helps us with the thought leadership work that we're looking at as well. So we've been capturing local, regional, national learning and really starting to lock down that benefit. Put together what's called a COVID-19 catalogue of change, which is some of the work that we've been doing with decision-making councils, bringing together colleagues who have been working at the point of care and in wards, units, different teams and systems across the country, who have really told us about what has worked, often sometimes unintended consequences of work that hasn't been successful, but also enabled us to translate that into case studies and start to build this catalogue and able to share it more widely. We've also developed a research portfolio, aligning some of the work that Bridie was talking about there as well, to again show the research that we've captured as nursing professions, that more widely too. And most importantly, I think, take the outcomes and start to embed them as well. There's a lot of research nationally that's being done, but the important part of that is making sure that these outcomes are used and embedded. We also have our atlas of shared learning, again with over 200 case studies, and again showing what we bring to the table and really demonstrating the nursing voice in this work. I was very fortunate a few months ago to represent Ruth at a remote conference at Geneva that the WHO and the International Council of Nurses and the International Confederation of Midwives ran. And one of the things that they also said, which really struck me very close to the work we're doing here, is that we need to use evidence within policy dialogue and make sure that outcomes agreed to are based on objective information rather than subjective values or political positions. And it's a shame that the slides are not moving forward, but one of the reasons I had slides today was really to show the visual around the work that we're also doing nationally, which is making sure we take that research and evidence, nursing and midwifery, and we underpin policy dialogue and policy development, and we then feed it into that system transformation and capturing these beneficial changes of work that's happened during COVID and also the restoration work as well. And in the middle of that triangle is really embedded in a collective leadership approach. So for us to be able to see this work, which I think is incredibly important, it has to be led and driven and embedded by point of care colleagues as well. And it's fine someone like me talking nationally and saying this is what we're doing, but this has to be taken up by all colleagues, particularly those who are working on a daily basis and really living and breathing this as well. The international strategic direction, which was raised at Geneva as well, was really interesting and very much aligned to the work that we're doing here. And the opportunities I think that we've got just now are once in a lifetime opportunities. And I'm not decrying or diluting in any way the challenging times that we've had and how tough it has been and continues to be as well. But we have got this evidence and integral to the response to the pandemic. And I think we need to look at that evidence and the data experience and capture that and then feed it into how we move forward. Feed it into our education processes to make sure that looking at impact is just business as usual. Make sure that we always evaluate the impact to patient outcomes, cost and health service effectiveness. And I think looking at cost is not, which is often thought to be something that is not a good thing to do. We need to look at cost and make sure that the impact we're having is of value, and if it's not, then we channel it into somewhere else that definitely does make a difference to our patients and those we care for and work alongside it as well. And some of you may be familiar with the State of the World Nursing report that was published last year, which brought together that research and programme evidence, overview of the research evidence, and really brought together and showed globally how coming together as a profession and putting the politics and policy to one side, there's far more professional commonalities than there are differences, and coming together and showing that impact because it's really, really powerful and something that we need to grasp and take forward. So I think that, as I say, moving forward, it's really important to make sure that we all come together, including how we position that impact and leadership and long-term planning as well. And
Sharon, is that okay if you take over until we pick up Susan's connection again?
I would be delighted to greet her. And
welcome. Thank you, Sharon. A little bit earlier than you anticipated, but always there, ready to jump into action. Thank you.
Absolutely. So thank you so much for that, Greta. So in terms of impact then, I just want to think about Florence Nightingale. So she has been credited by many of our military historians as being the founder of British military nursing. After she led a group of 38 volunteers out to Scutari in 1854 when they cared for the British soldiers during the Crimean War. And really, one of the things that I want to explore is Florence's legacy and impact today on defence nursing. So my role, I provide the strategic leadership, direction and advice on behalf of the Surgeon General to meet the nursing component of the Defence Medical Services in order to meet our current and future healthcare, both in the firm base and on operations. The role encompasses our regular reserves and MOD civilian nurses, and I certainly couldn't do it without the support of the single service nursing leads in the Royal Navy, the Army and the Royal Air Force, and our Chief Nurse for Defence Primary Healthcare Services and our Defence Professor. So my background, I trained in the Army, so I started my training in a military hospital, and it was a military hospital, but we saw both soldiers and our local civilians. I started my training in 1990, and at that time, we had our training then suspended in our first placement because the clinicians were all then deployed to go out to Iraq. So certainly hearing from some of our student nurses and the work that they had experienced during the pandemic, I can absolutely relate to that because we were then employed as healthcare support workers until our training was restarted. Once training was restarted, we then worked in both the UK and overseas in military hospitals, and we also went out to NHS hospitals. And on qualifying then, I worked in secondary healthcare, primary healthcare, and as a recruit instructor. But if I reflect on what has, or the change that has gone on in both the NHS and the military, since I started my training in 1990, it has been significant. And I think the first real change that I became very aware of in the military was Defence Cost Studies 15. So that happened in 1994, and it recommended the closure of our military hospitals in the UK and in Germany. And the rationale for that was it really wanted to look at and give us a broader spectrum of clinical care, particularly in relation to trauma, in order to meet our deployed role. And so now we no longer have military hospitals. We have our nurses working in Defence Primary Healthcare Services, but our nurses in secondary healthcare are actually working in NHS host trusts. So we heard yesterday Ruth talk about the Nightingale Hospital, the field hospital. So we work very similar to that in the fact that when our field hospitals deploy out to Sierra Leone, to Afghanistan, they pull together our military staff that are embedded within the NHS, they form as one group, and then they deploy out on the operation. So just thinking about Florence Nightingale and her impact, and Greta talked both today and yesterday that it is 166 years ago, Florence would have been in transit with her nurses to Scutari, and that was at the behest of the Secretary of State for War, Sidney Herbert. They landed in Scutari on the 4th of November, and I think I just want us to think about what that must have been like. They would have been completely fatigued from the journey. So we heard from Greta, it was 2 weeks that they were in transit. When they arrived, they were completely unprepared for the situation that they were to see on the ground in terms of the conditions that the hospitals were in. It was a disused barracks that had been turned into a hospital. The conditions that the soldiers were being cared for out in the Crimea, you know, they had maybe, you know, a few bedpans between hundreds of soldiers that were being looked after. The hospital itself was filthy and it lacked essential items such as medications and basic dressings, as we heard. And also the Florence and the nursing staff were met with some hostility from particularly the doctors, who didn't feel that they should be out there. So I just want us to think about the impact that that must have had on Florence and the nurses in terms of their mental and physical well-being. And I think Baroness Watkins today used the great words to describe Florence in terms of her being a feisty leader. So as well as these well-developed leadership skills, in order to kind of deal with that situation, she had to show huge reserves of compassion, kind, resourcefulness, resilience, flexible, tenacious, and courageous. And certainly thinking about our defence nurses now, they have to espouse all of these characteristics, and just like Florence and her team, have to be ready to deploy on operations at any given time. And so how do we meet that requirement? I think the first element of that is our preparedness. And as part of that, we have what's referred to as the Defence Operational Nursing Competencies, or the DONC as we refer to it, which provides a proof of clinical competence. It also can be used as a credentialing tool, particularly when we're working so much with our allies and sort of interoperability. And it can also be used for a tool for professional advancement. What do I mean by that? It can be used as nurses as a means to demonstrate their suitability to enter into specialist practice. But that is one element that we have. The other elements that we look for is simulation and immersive training. So how do they implement the DONC into practice? And they do that through things like our hospital trainer that we have up at the Army Medical Services Training Centre up at Strensall, which that has a fantastic ability to look at the individual, the team, and across the whole system in terms of how they're performing. And it will deliberately put the system, the team, and the individual under pressure. But it's done in a very controlled and very safe environment. And they will use things like, they've got fantastic groups, such as the Amputees in Action, which when you see them in all their casualty stimulation, and you add in the additional noises, the sort of phonetic activity, it really does put people under huge amounts of pressure. But what that allows our clinical staff to do is one, have confidence in their abilities when they deploy out. And two, have confidence in their team ability. It takes away that shock and awe. And each of the scenarios, if we think in the past 10 years where we've deployed to, so the hospital trainer will look at things like our polytrauma for things like kinetic operations in Afghanistan, through to the Ebola crisis in Sierra Leone, and latterly the United Nations mission in South Sudan. And each of those can be slightly tailored to give the clinicians that sense of what they may be expected in terms of they may have to go into a non-permissive environment, very unpredictable. And so it's almost by rehearsing these skills, it's preparing them from the unpredictable. And so that shock of awe of deploying into these austere environments is removed. But that sense of team really came through during the pandemic, and certainly speaking to many of our defence nurses who have been working with their NHS colleagues, they've really, so I think Carol Keffer described it beautifully this morning, that operational tempo. They have described their work in the pandemic as similar to that operational tempo. But they've also learned a significant amount from working with their NHS colleagues in that environment. And I think that's sharing. So when we deploy out to operations, normally we work away from our support networks of particularly our families. Everything is put in place by the nurse before they deploy out there. So they don't need to think about, you know, who's looking after the kids, who's managing the house. All they've got to concentrate on when they're deployed is making sure they provide the best care to their patients in that operational environment. Well, of course, that was different during the pandemic. Our NHS colleagues would absolutely have recognised that for some who were having to shield away from their families. But for many of our military nurses, they found that a different tempo in terms of they had to consider their families. It wasn't that they were away from there. And the huge amount of lessons that they were able to share. So certainly when we come back from operations, there is a significant wraparound in terms of our post-operational stress management briefings, and also a period of decompression of leave to spend time back with their families. And throughout that, the golden thread is the leadership training that we provide to our military nurses. And really it's about focusing their military skills and their clinical skills, so they're absolutely to the highest standard to deliver care on operations. So I think one of the things that we do within the military is reflecting on our past to inform us and better prepare us for the future. And certainly we know Florence wrote significantly on improvements for soldiers out in the field. And in fact, in our General Officer Commanding's office, so he looks after all the military in London, he has got letters from Florence that are framed in his office. And so it shows through things that they're kind of reflecting on. And we see that in the Army's recruitment video, which was fantastic to see them link the Florence Nightingale into the recent Army recruiting video, which I thought was fabulous. But certainly our defence nurses today continue to champion our service personnel, whether that's in the Royal Navy, whether that's in the Army or in the Royal Air Force. And Florence Nightingale was one of the first recipients of the Royal Red Cross, which is a state award awarded to military nurses for exceptional services to duty, to nursing, devotion to duty and professional competence in military nursing. And I think during the pandemic, our defence nurses have absolutely stood shoulder to shoulder with our NHS colleagues in secondary healthcare. And they have continued to espouse the professionalism, leadership and compassion to care for patients when they're at their most vulnerable. And I think testimony to that was the many nurses that were recognised in the Queen's Birthday Honours list. And I was delighted that we had 8 nurses recognised in that. And particularly that was for their work during the pandemic, and a significant number for their work particularly involving infection prevention control. And I think they are a real fitting legacy to Florence Nightingale and her impact on defence nursing.
Thank you very much, Sharon. Marvellous. I don't know whether you know this, but you might have increased military nurse recruitment with your last 10 minutes of explaining the role of the military nurse. So thank you for that. Really great skip through a history of military nursing from Florence, the abolition of military hospitals, through to COVID and how military nurses are working shoulder to shoulder with NHS staff now. But importantly, using the impact of what you've been able to achieve through your competencies, your military-wide competencies, and sharing that with nurses in the NHS. So it's always been a great partnership, but particularly through COVID, I think the NHS have learned a huge amount from your experience of being deployed and importantly trying to manage and look after the families who would normally be left at home. So fabulous, thank you so much. So we're going to move on now to Bridie, if that's okay. We're trying to sort out Susan's IT. So Bridie, would that be okay if you step in right now?
Yeah, not a problem at all.
Thank you so much.
No, that's great. Now, it's really good to be here, and I'm going to take a different stance in terms of impact. So I'm going to talk about impact of evidence in today's rapidly changing world of health and social care. So I'm a clinical academic. I work in a university, I lead research, and I work clinically in critical care. And my focus is very much on a day-to-day basis around practice and research. So I'd like to explore it in light of the challenges that we've had and are facing for nursing in this strange year. So let's start by exploring its impact generally. Like many other countries across the world, the UK engages in a research assessment exercise every sort of 4 or 6 years, roughly. This assesses the quality of research in UK higher education institutions. And in 2014, the assessment changes, there were changes made to the assessment groupings, and nursing no longer had its own unit of assessment. Instead, we went into a mixed group with submissions from allied health, dentistry and pharmacy. And so in 2016, a group of people, myself and several of the members of the RCN Research Society, decided to look into this a bit more. And it was led by Danny Kelly from Cardiff. And we wanted to understand the impact of submissions focusing on nursing. So impact for the REF was defined as an effect on changes or benefit to economy, society, culture, public policy, health, environmental quality of life, and it was all beyond academia. So we analysed the impact case studies that had been submitted to try and categorise wherever possible the range of direct and indirect impact cases that could be traced back to nursing. So these included the kinds of impact that nursing was contributing to and who was undertaking nursing in terms of research. And we did it because of the fact that this was the first time that impact had been used in this way. And we found 469 entries in the REF database, and which was submitted across 11 units of assessment, with a really wide range of topics covering human lifespan, ranging from reproductive health care to end-of-life care, and a mix of health service delivery settings and other initiatives. Unfortunately, we located 50 case studies where the focus was on nursing, but that the team of investigators didn't include a nurse. So therefore, there was a significant body of research which had been conducted with really strong relevance to nursing that hadn't been associated with the profession at all. In other words, there was a big hidden impact for nursing research. And I think moving forward, we need to pay much more attention to this to ensure that the full impact of nursing research is recognised in order to mobilise the contribution of nursing to national policy and practice. Interestingly, the chair of the panel at the time, Hugh McKenna, he commented that more work by nurse academics could have been submitted to REF 2014. And in his message to nurses at the RCN International Research Conference in Nottingham in 2015, he challenged institutions to really raise the game and recognise the high quality of research that's been undertaken by nurses. So when you look at that, in that REF 2014, nursing had 80% of its submissions judged to be either world leading, i.e. 4-star, or internationally excellent, which was 3-star. So without a doubt, we're doing a really good job. And it's the same across the world. You know, we can really stand with our heads high. Here in the UK, we're busy, every UK institution, no doubt, is busy preparing for the next Research Excellence Framework. And I really do hope that we see a much larger submission of research that's really related to the wide-ranging contributions made by the nursing profession. It needs to I'm sure there's some really impactful case studies that really reinforce or reflect the contributions that this research has really made to people, to policy, and to practice locally, nationally, or internationally. So this year is the International Year of the Nurse and Midwife, as all of us recognise. And it's been really interesting to see the rapid response through research to generate evidence to inform policy and practice, particularly around the impact of the COVID-19 pandemic on nurses. And in the last few months, the Chain Network, so hopefully you are aware of that, but so the Chain Network, they launched 3 new subgroups related to COVID-19. And these groups aim to provide an easy way for members to share intelligence on different aspects of really what's a fast moving and fast evolving subject. We need, it was also aimed to keep abreast of learning opportunities and resources, and where appropriate, get some get people joining together with specific objectives. So the new subgroups, for anybody interested, research into COVID-19, rehabilitation after COVID-19, and also long COVID. So check out those, because I think they're another way in which we can help to demonstrate impact, particularly by working together. One such study that I have been involved in, which is very, very recent, and it's come up through COVID, is the ICON study, looking at the impact of coronavirus on nursing. It's been led by Keith Cooper from the University of Warwick, and it certainly attracted a lot of attention in the UK because it surveyed thousands of nurses before, during and after wave 1 hit the UK. The results clearly show the impact on nurses' physical and mental health and well-being. And the findings have helped to shape health and social care support strategies in this vital workforce. And we've released these findings as we've gone along so that we can truly try to really get this evidence up there. So it's really live evidence. As a follow-up to the ICON study, another study has been undertaken. It's been led by Jill Mabon from University of Surrey. And we're currently analysing the data from that, but it's interview data, and it's been generated from around about 40 nurses, all of whom were involved in the surveys, the ICON surveys. And these nurses have all been involved in health and social care during the first wave of the pandemic. Some had been redeployed, others have remained in their usual roles, but often with a very, very different focus. So we've had acute, we've had critical care, we've had community, and we've had care homes, all of which are featured. I think significantly and strikingly, all of us who were interviewing these nurses were significantly moved by their accounts. PPE challenges featured strongly, but also much more positively, the ways in which nurses use their initiative to overcome such difficulties. The impact of teamwork, the value of pulling together, the emotional cost of care, all of that came through. The strength of nursing identity though didn't waver, and most were really proud of being a nurse during this time. We have to use evidence of this nature to really capture and share the importance of the nursing profession in this rapidly changing world. We've all seen evidence and efforts made to increase surge capacity, especially in areas like ITU, and we heard about, we've heard about the Nightingale hospitals. But there's been other similar areas as well. It's not, it's across the board. Every sector's been involved. However, none of the changes, none of the flexibility that we're trying to incorporate at the moment is going to work without high quality expert nurses, and all of these are in short supply. So they're interlinked. We have to do something together. It'll be so interesting though to redo the impact case study evaluation that we did and do it in 2021 or following 2021 or in the ref after that. And I really, really hope that we're going to see many, many more impact case studies that are being assessed as world leading or internationally excellent. But lastly, I want to highlight just 2 initiatives that I think really demonstrate the massive impact of evidence on people's lives. So it's the impact of evidence that's been generated by nursing or been led by nursing on people's lives. I'm sure many people listening today are familiar with the phrase #NPJ paralysis. This has become a global phenomenon, and it's a very recent times, and it's been led by Brian Dolan, who now lives in New Zealand, and I'm really envious of him because I had a wonderful 7 years there working as a nurse and got New Zealand citizenship. But this campaign, it's transformed the practices of care for so many people in hospital all over the world. And it was such a simple idea. It was all to do with getting people up, getting them dressed, getting them mobilised, making them feel better and get them out of hospital quicker. And the idea has taken off. It went viral. And there's massive impact case studies that can be captured in relation to that. The other one's much more recent and really close to home. So my colleague, Kate Tanton, is a specialist sister in critical care rehabilitation at the University Hospitals Plymouth. And it's where I work in the intensive care unit. Importantly, she's the brains behind #RehabLegend. So we know from evidence that ICU patients really benefit from early psychological intervention and ICU rehabilitation. The evidence is really clear that doing that, getting that early intervention, it's safe, it's feasible, it clearly improves functional outcomes, decreases ventilator days, reduces delirium, and decreases ICU and hospital length of stay. So thinking about that, it's really important that ICU patients are given maximum exposure to rehabilitation during their ICU admission. And this has become even more, this is just as important during the corona pandemic. In Plymouth, Kate has been this driver really behind the Secret Garden. And it allows the whole of the interprofessional team to really promote, enhance and facilitate rehabilitation in a non-clinical setting. So supporting patients and loved ones really to help them feel normal and to engage with their rehabilitation needs and their future. Kate's launched a social media campaign on Twitter, and it was launched in June 2018. To really try and get the idea of celebrating anyone who's done anything to enhance, to support or facilitate rehabilitation. She's now shared over 800 Rehab Legend badges, 50 light boxes, 200 cards, and shared the idea online with over 50 different countries and healthcare teams worldwide. I myself have been involved in bagging up the badges, so I know some of the extent of where they've gone to. The online reach has been in excess of 40 million. So pretty tremendous stuff. And the idea is to share patient, loved ones and staff stories to really promote those little things that happen every day, promoting rehabilitation and recovery. And it's so important at this time when COVID is really limiting visitor access in acute hospitals as well as care homes. I've seen firsthand the work of the rehab team at University Hospitals Plymouth. And during COVID, the efforts that they went to in order to get ICU patients rehabilitated in the unit, often whilst on ventilators, and get them outside in the Secret Garden to help them orientate and motivate. Here you can see the team, well, some of the team. And it's with this picture's provided with a permission. And it was two of our sickest patients who contracted COVID and were ventilated for weeks. And with rehabilitation, these gentlemen were discharged home within 1 week of leaving ICU. One of them, the one on the left-hand side of the screen, was even recently got to the top of Brown Willie in Cornwall, which is our highest hill. And that's an amazing feat for a gentleman in his 80s, especially given his journey this year. So Kate would say it's all about the team. And yes, it is, but someone has to have the ideas and do something with them. I want to see more of those ideas from nurses like Kate and Brian. We owe it to our patients to share those thoughts. And as Carol has just said this morning, when she spoke earlier, we need to have nurses riding the crest of the wave. And I think this is a really good example of one nurse who rides that crest. Thank you.
Well, Bridie, that was amazing. Thank you. And again, I want to sort of crystallise that into a story of REF in 2014 with a look at the case studies and the shocking news that you told us that even though a lot of those case studies involved the practice of nursing, nurses weren't involved on those research teams. And then all the way through, and a lot of those case studies were world leading. I think you said 80% were either 3 or 4 star. And so the nurses have got the potential to do really great research, and they're doing it across the world. They can stand up high with their head held high. And actually, if we do it well, we've got the ability to really inform policy and practice. But I guess that was the old days, and we're moving on. And I think what COVID is, and you've highlighted what COVID has shown us, that actually we can do things really quickly. And the ICON study and the study that University of Surrey are involved in, and of course of using some of the nurses and midwives to access our Nightingale Frontline service. What that's shown is that the research can happen quickly, and we can show the impact that that's having very quickly, and we need to do something about it. So as soon as we've got the results, we need to be able to use those results to change policy and practice. And then the two fabulous examples of Kate and Brian, and how quickly an idea turned into a global movement, really. And Brian's end PJA paralysis. In fact, my husband is going into hospital in a couple of weeks' time for a total hip replacement, and I reminded him he doesn't need to take pajamas because of Brian Dolan's research. So he was rather pleased about that. But that's fantastic. Thank you so much. There are some questions that we'd like to pose to the panel, and I guess a really quick one. We've got a few minutes before we break for lunch. A quick one is that I guess we've heard about how Florence was a trailblazer and how she spoke to power, how she used her data to influence policy. So I'd like to ask the panel your thoughts on how we can do that to encourage nurses and midwives to contribute to and influence policy. What else do we need to do? Is that, do we, as David Benton called it yesterday, do we carry on working as a soloist, or do we join the orchestra? So panel, I'd be glad to hear of your thoughts around how can we start to contribute and influence policy. Shall I ask Sharon that first, please?
Hi, Greta. Sorry, there's problems with my mute button. I think it's a really key one just now, and it's something that we have talked a lot, particularly within the military, with our single service nurse and defence professor. I think that the big thing is about empowering our nurses to feel that they can contribute to these policies. And as everybody has highlighted today, I think the opportunity with the way that we're working just now in this virtual platform, I think is definitely one that needs to be exploited, because I think when you are in that virtual space, the connectivity and the networks that you're able to establish are far greater. But it's also about changing our culture in terms of the policy, and bringing some of our more junior staff in so that their voice is being heard, that they feel that they've got something to contribute. And certainly with that, I think the fantastic opportunity with the Florence Nightingale Foundation Academy membership is a way that we can actually then start to bring people in to prioritise our policies and to have a say.
Fabulous, thank you, Sharon. Bridie, can I ask you that same question? What do we need to do to start to make sure that nurses and midwives are starting to influence and impact on policy?
I think it's really important to look at how we, it is, as Sharon was indicating, there's a culture change that's needed. I think it's recognising that every every midwife has a voice, and if we can try to get the try and encourage our learners to really adopt that, to really adopt that voice. We've got the Council of Deans of Health, we've got the 150 leaders groups that they've got going. It's vital that we look at those people and really inculcating them that this is so important, that leadership is, on many different levels is vital, but it's really, really vital that we have those trailblazers, we have those people who are willing to be those tall poppies who are going to stick the head above the parapet. It's easy to keep your head down, but actually if you've got something really fervent to say, then get it out there and say it.
Fabulous. So I've heard already, power our nurses, use these virtual opportunities as to increase our networks, start changing the culture. So what else do we need to do that will make a difference? Bridie, every nurse midwife has a voice. We should start to use it. and importantly, how do we encourage the next generation? We should start to develop those as trailblazers, and we can do that. So I wonder, Susan, are you back, or are you still not there?
No, we've lost her, Greta.
Lost her completely. Okay, so we're back. We're down to a panel of two. Well done, you two, for keep going. And a similar question, but slightly different. So, Bridie, you've spoken very eloquently about the value of research, and I want to know, how can we ensure that nurses and midwives know that the research is part of their job, it's part of their role, it's their responsibility? Any ideas about how we can start doing that so that it's part of changing the culture?
I think, yeah, I agree with you completely that it has to be everybody's responsibility. But I think one of the things that we need to do is get over this fear of using the word research. You see, so many times, I'm just as guilty of it today when I said I want to look at the impact of evidence in today's world. We need to really start to embed the R word into the code of conduct. We need to embrace it into the NMC standards. We need to get it at that high level. We've really got to dispel some of the myths that it's for somebody else to do. It isn't. It's a bit like we had to do with quality. Now everybody accepts that quality is everybody's responsibility. I think we need to do the same with research. Everybody can get engaged at different ways. We're not expecting everybody to be the world leading researcher, but they should be able to use research. We're really getting we're looking at our students. They're coming out with many are coming out with really good classifications of degree. Let's keep that use of evidence and use of research really going in practice.
Fabulous, thank you. Sharon, anything to add to how can we make certain that research is everyone's business? And as Bridie quite rightly said, it's not everybody that needs to be a world-leading researcher, but it's everyone's roles. Any suggestions about how we can do that more effectively?
Yeah, it's really interesting, and certainly our Defence Professor of Nursing, Di Lam, has been done a tremendous amount of work in trying to address this, particularly for our nurses in defence. And I think Bridie's absolutely right. It's about changing the culture, about demystifying researchers. And certainly I think part of that is one of the things that we're trying to do is almost legitimise the role, that people shouldn't be expected to be doing research in their own time. It's about making time in their job plans to participate in that, to sort of galvanise that thirst for knowledge, that quest to try and close that knowledge gap. So then they get used to the taxonomy, the language, and it becomes less of a fear, and it starts to demystify that process in terms of research.
Fabulous, thank you. So a third question in amongst those two is a follow-on, really. So I guess my viewpoint on this is that there are lots of nurse academics now who are doing fantastic research. It's published and then it stays on the shelves. So I think we've got an additional responsibility to make certain that that's turned into some evidence-based policy and practice. And so we've heard about the impact nurses and midwives are making daily, but how do we share that learning? I guess I don't really want to be hosting another conference in a few years' time discussing the same topic. So how do we build on and share that learning? So has the panel got any ideas? What do you believe that we've got the correct infrastructure now? And how do we share those experiences across our organisations? And then what do we need to do about sharing those experiences globally? And if not, what should we do? So over to you too. So back to you, Sharon, if that's okay. Any ideas about what, not being here in a year or two's time talking about the same thing? What do we need to do now that we need to commit to?
I think you're absolutely right, Greta, and it's something that we feel very passionately about within Defence. And I will just use an example of one of our previous Surgeon Generals. The US coined this the Walker dip, in the sense that we were constantly in every sort of conflict historically, when he looks back historically at all the sort of conflicts, we had this huge amount of innovation and research and sort of lessons that were captured, but at the end of that conflict, that learning was lost, and we almost had to relearn it again at the start of a new campaign. And importantly, that intellectual deficit was repaid with service personnel's lives because we hadn't captured those learning. And so that's something that we have absolutely strived for within Defence, to make sure that we're learning the lessons. So we have got Defence organisational learning structures now that capture those lessons, and as they're happening on the ground, we're then feeding that back in through our simulation and immersion training, and also through things like the standing up of our academic department of military nursing, again, to make sure we're capturing these lessons and sort of feeding them back in through that way. I think as well is, again, similar to my previous answer, the opportunity that we've actually got now in terms of the far greater reach to share these lessons, I think is really important. And I think you see that today with how many we've been able to get on this virtual platform. Certainly, we know through Di Lamb's work with the International Committee for Military Medicine, they have now, for the first time in its history, published the supplementary journal, which has included abstracts from nurses to get that message out there, to capture the lessons that the nurses have been doing. So again, that's been a fantastic opportunity. And I think just as well, and I think Bridie mentioned it in her chat earlier, is we've got to think about the generations that are coming up. You know, I think the NHS employers, where they work on Mind the Gap and sort of Generation Y and Generation Z, they want to see that immediacy of the lessons, of the information coming out. And so these platforms is an ideal opportunity for us to springboard these messages out into the sort of, through our own organisation and wider, you know, on a global scale, which I think is absolutely fabulous.
Thank you very much, Sharon. Bridie, any additional thoughts from you on this subject?
I think very, very quickly, I think we need to think on it more. We're very good at sort of keeping things within country and things like that. Let's see if we can get through some of those, get across some of those borders. Are there some networks? Is it through things like using research councils, say NIHR, NHMRC in Australia, the US ones? Let's see if we can combine things that way. There might the nurse and midwifery incubator might be a possible route into that particularly global sharing. International Council of Nurses, is there a way that they can have a role in that, in providing some infrastructure to put in place to allow nurses to put ideas on, to share ideas, and to get those collaborations really moving forward? Because that is the way, I think that's going to be the crux of it, to really really get that global impact.
Amazing, thank you. I'm so sorry that Susan hasn't been able to join us, but I understand from my team that we will record her presentation and have that available on our YouTube video. So thank you very much to my panel of 2 plus 1, Susan. We did get the majority of your, if you're still listening, Susan, we did get the majority of your presentation. We certainly have your slides, which we will use as part of our YouTube upload. But I think there's lots of learning there. I think you've been very honest, and you've given us some real examples about what we can do for the future. So you've taken us through military examples of military capability, how the NHS have learned from that. Bridie, you've talked to us about the use of, or the non-use of, nurses in nursing research, and how that is changing over time, and we've managed to do that very quickly through the research on COVID. And Susan, the slide that we saw had really great examples about how the NHS is really capturing great examples of some evidence and using that as a bit of work to populate across the country, for instance, end PJ paralysis. So how can we do this more effectively? We've got our next generations coming up. They are the generations that have been used to this digital platform. They are the ones who've been who have research as part of their undergraduate education. We need to need to use that that quality, that new level of nurse to really help our practice organisations, wherever we work, in hospitals, communities. We need to use the younger generation to help us do that. And whatever happens, the evidence that we have, we need to develop some networks. So the NHS has now, within Ruth's team, has now got a joint role in head of research and innovation, helping Ruth's team, snapping up the evidence that's been generated and then moving that into policy. And we've seen that with Susan's slides. And Bridie, you mentioned the nursing and midwifery incubation hubs as part of the NHR. Really good vehicles for making those things happen. But I guess there's so much to do still. We've still, I think the audience that have come on today, we had 200 yesterday, we've got about 170, 180 people today. I think we've all got our own ideas, but I think if we can individually, but within our own networks, collectively commit to how do we translate this really fantastic evidence that's coming out, that's nurse-led, and make certain that we pick it up and do something really valuable with it, so that we are showing the impact that we're having, and hopefully that's starting to develop our narrative about the highly skilled professions that nurses and midwives are. So I want to thank you all very much this morning for a stimulating session, lots of ideas, and we certainly, I think, as this delegate, will take some of those ideas forward. So it brings us to 12:30, or just after 12:30. There is now a break for 1 hour until the next panel session, which is at 1:30, and that will be chaired by Gemma. Slight alteration there, but I'll let Gemma explain that a bit later on. So please shake your legs around, move around, have some nutrition, have some hydration, and we look forward to joining you back at 12:30. Thank you.
Thank you so much, Greta. And just to encourage you, our panellists are going to stay online and answer any questions that you do have through the Q&A function on Zoom. There are some questions already there, and both Bridie and Sharon are happy to respond to further questions through that function. So please do keep the conversation going with them. And also, if you're using Twitter, you'll see that what Florence means to me as a hashtag is generating huge amounts of activity on Twitter. So please do join in that conversation on our social media as well. And as Greta said, our pre-recorded concurrent sessions are all available at the YouTube link that's been emailed to you, and it's also been added to your the Q&A. For those of you that haven't got access to that, we hope you'll have a chance to enjoy some of those presentations. And I just want to make a little bit of a shout out to one that was recorded by Professor Ian Norman, who was the chair of our scientific review committee for the Nightingale 2020 conference. If you don't listen to any of the videos, please do listen to that one. It's got some very important and significant messages for us all as a profession. So see you back again at 1:30.